I wanted to start by saying thank you to our sponsors, OACHC, Cardinal Health, and United Healthcare Community Plan. Very special thank you to all of you who've joined us this morning. And, we decided to put on this bonus call kind of at the last minute, and have been very grateful for those of you who have carved out time in your schedules to join us. I'd like to welcome Jamie Behrens. Jamie's the Chief Executive Officer of Crossroad Health Center, and Maria Lucas-Asbury, the Quality Director at Crossroad Health Center. While Jamie and Maria weren't speakers during the series, we thought it was really important when we put together this call to talk about practical approaches to operationalizing these things we've been discussing, to have folks that are on the front line join us today, and we look forward to you, Jamie and Maria, sharing that on-the-ground perspective with us. If you could just give me a quick hello, Jamie and Maria, so I know we've got you live on audio.
Yes, good morning, everyone.
Good morning. I'm happy to be here.
All right, thank you. Next up, I'd like to welcome Tracy Davidson. Tracy is the Chief Executive Officer of United Healthcare Community Plan of Ohio. Tracy did a great webinar for us last week, brought a lot of great perspective. We had a lot of excitement around some of what you shared last week, Tracy, and we look for much more of that on the call today. So thank you for carving out time in your very busy schedule to join us.
Good morning, everyone.
Next up, I'd like to welcome Randy Runyon. He's the CEO of OACHC. Randy kicked off our webinar series many, many weeks ago, and brings a wonderful perspective to this panel today, in that he works with health centers all across the state and has seen the good, bad, and the ugly of what's going on out there. So we look forward to hearing about some of the best practices that you've been able to witness and be a part of out there, Randy. Thanks for joining.
Thank you. Glad to be here.
And last up on our panel, last but certainly not least, the gentleman who moderated the webinar series these past many weeks, James Pat. He's the founder and CEO of Insight Health Systems. And James spoke to us about data interoperability and information sharing a few weeks ago, and he has decades of experience in that space. So thanks for joining us here today, James.
All right, thanks. Good morning, everyone.
All right, so again, if you have questions on the call, please go ahead and go to that chat box, select me, Michael Schechter, say presenter in parentheses, and shoot a question over, and we'll get that answered for you. But to kick us off, we'll start covering off some questions that have already come in. And to kick us off, I'm going to start with kind of a big one, and in turn, I'm going to push it out to each of our panelists for some input on this, because it's a broad enough question. I know that everybody's going to have a perspective on it. So here's the question. Much of what we've discussed in this webinar series is big picture, multi-year plans for transforming healthcare, but we need to make an impact today. So where should we be focusing today? What incentives for value-based care are available today that we might not be aware of? What resources are available to us today? So I think the questioner wants to know what they can do today. So I'll start by kicking that over to you, Randy, to get us rolling here.
Okay, so I'm happy to do it, and thanks for inviting me here today. And so I really enjoyed the presentation we had last week from Tracy. I just listened to, I didn't hear it at the time, but listened to it yesterday. And Tracy points out that United Healthcare already has a program in place, or is developing a program in place. I know several other managed care companies are actually on the ground now with performance improvement programs that can result in shared savings. However, one of the things, there's several big obstacles to this, and this is sort of the ugly of the health center, is that, and I think every health center director would agree with me on this, is that a lot of these systems are based on billing information through CPT and procedures codes, and health centers are notoriously bad at documenting what they're doing through the billing system, because, particularly through Medicaid, they get paid regardless of, just essentially a diagnosis and one CPT code will do the trick. Unfortunately, you're not getting credit for a lot of the good work that you do. We found this out when Medicare was developing a new payment system for health centers, that they looked there and found that there was very little background information in terms of CPT codes about, that you could document other procedures that were done over and above the other visits. So I've recently was privy to some information from one of the managed care companies, and I knew in a particular health center I was looking at that they do an excellent job with, I can't remember the particular situation was at this point, but when I shared it with the CEO, she says, well, that's just another example. We just don't bill appropriately and capture all the information. So there's an existing programs out there, but you're going to have to do some work to make sure that you're getting ample credit for what you're doing. The other sort of preparatory thing, and it's not going to be developed into money tomorrow, but if you're not traveling down the road for patient-centered to medical home, you should really reconsider that decision. 33 states, I believe, have programs through Medicaid that pay reimbursement for patient-centered medical home per member per month reimbursement. Ohio is not one of those states, but soon very well may be that. And so it may not be a situation for tomorrow, but it is for the day after tomorrow or sometime in the next 6 months to a year. So that's my opening sort of gambit of challenge to the members.
Okay, great. Thank you for that. And since you brought up Tracy's name right at the beginning, I'll kick it over to you next to react to that around what folks should be focusing on today, what incentives might be available, and what resources they can tap into right now. Tracy?
Good morning again, everyone. I appreciate the opportunity to be here this morning. And thank you, Randy. I'm really impressed that you went back and listened to the video or the audio recording yesterday. I also have our Chief Financial Officer with me today, Dale Moore, and so we may tag team a few questions, but I'll take this one to start. Randy is absolutely correct. One of the key areas of opportunity and where we can be focusing right now is understanding your gaps in care. And what that terminology means is really understanding the evidence-based types of interventions that the consumer population that you treat should be getting from a population perspective, as well as how you code it so you get credit for it. All of the programs that I referred to last week, all the way from the primary care incentive program all the way through capitation, really are benchmarked on quality criteria and being able to identify gaps in care. So let me translate a little bit of what that means. The gaps in care piece is terminology that the managed care industry uses to look at populations or individuals who should be getting certain types of services. For example, preventative care, maternal care for our pregnant moms, postpartum care after delivery. Those are some specific examples. And so really understanding the individuals that you're treating in your health centers and knowing where they are in their trajectory of health care is a very important indicator right this moment to know more about. And I realize, too, that one of the areas that Randy alluded to is resources and understanding and knowing what resources that you have to help do that work. It's not easy. So I think the other kind of practical consideration is the data analytics that you're utilizing and or what resources you have to help you do that. Many of the managed care plans do have resources. We all call them different things, so I'm going to use our particular model as a example. But all 5 of us do have a variety of ways we do this. We call ours CPCs. They're clinical practice consultants. And they actually are nurses who work alongside your clinical teams and your billing teams to better learn and understand how to bill the proper codes to get credit for the work that you're doing. And it is the foundation of all of our VBC programs. So I think that we'll start there, and then we can continue kind of the conversation around other questions, but understanding your data and being able to understand your membership or your panel and where their gaps in care are, I believe is probably the first practical step that all the centers can take.
Okay, great. Thanks, Tracy, and we'll certainly, I'm sure, be diving deeper as this discussion continues. I'd like to kick that exact same question over to Jamie and Maria next. So, you know, the question is, what can we do right now? Well, you're already doing a lot of stuff right now, so perhaps you can share about some of the quick wins some of your colleagues on this call today might be able to generate.
Well, one of the things we've done Randy had mentioned a shared savings. We have an arrangement with one of the Medicaid managed care providers that we share savings if we're able to decrease the ED utilization of our patients, as well as able to, on the pharmaceutical side, that we're able to get more generic drugs prescribed than the name brand or higher tier. Mm-hmm. So, you know, that's a very good opportunity for a health center. The issues we've had is, as far as on the pharmaceutical side, that, you know, if a patient goes to a specialist, you know, we don't control what that person prescribes, but that still counts against us. The number of patients, you know, we are assigned certain patients from each managed care organization, and there's some that just, you know, that'll go other places to other providers not associated with our health center, and they will they still count against us too, because we don't control that.
Mm-hmm. Yeah. The other approach is, the other thing that we've done in partnership with the managed care companies has been to look at population management and identify patients that would benefit best from care coordination. And we're using some really imaginary means for making that outreach happen. So it helps us to clean up that list of patients that come to us from the managed care providers. At first glance, many of them don't appear to be our patients. We've never seen them. But we have our outreach volunteers call those patients, see if they have a medical home, and if they don't, we set them up for their first appointment and encourage them to come here for their medical home cares. So it's just one of the many ways that we've started to link into the population management concept. It also helps us with the financial incentives with the managed care companies. With many of them, if we sign up a patient, there's a financial incentive for getting them to identify us as their medical home. If we're able to meet all of the criteria for managed care for chronic care diseases, there are financial incentives for that as well. So one of the major things we've done recently is to take a step back and not keep working harder, but to look at things a little bit differently and work smarter and utilize our resources a slightly different way. And also follow the lead from our patients. We're paying more attention to patient-centered care and listening to what their preferences are in terms of how they'd like to be communicated with and those sorts of things. And so that has really driven a lot of our most recent improvement initiatives.
Michael,
that's great.
Michael, this is Randy. Can I follow up on that too?
Please, yeah.
And I just wanted, that was one of the things I wanted to address in my opening remarks is attribution, and the folks from Crossroad spoke very eloquently to this. So we judge, looking at the information we've been given by managed care companies, that 40 to 60% of the patients that have been assigned to you by a managed care company you have never seen. So they are either never seen by anyone, or they're being seen by some other provider. So how are you going to be paid for performance when you're not performing or maybe you're relying on the performance of some other provider, or you're not seeing the patient at all? So that's a real quandary that we need to figure out together with the managed care companies.
Hey, Randy, this is Tracy, and I'd be happy to respond to that, too, because you both are well on point. Maria brought up some really great discussion points, and that's around, one, member engagement, and two, about attribution. So if it's okay to step back a bit to understand the quandary that the industry is in around attribution. We are, all 5 of us, have self-selection, which means that when a consumer becomes eligible for Medicaid, they elect a plan. And if they elect a plan, typically they've had a relationship with a PCP because they've kind of understand the insurance industry. Or we have some kind of a discussion with them because they've selected us and we're able to help direct them to an appropriate choice. The other 50% of people are auto-assigned to us, and the state uses what they call an intelligent algorithm to identify consumers based on their past history of provider usage or past experience with the managed care plan. After it goes through the intelligent auto algorithm, it actually does the eeny, meeny, miny, mo series, and so it just kind of does the round robin approach. And so from a United perspective, one of the things that we are really focusing on across the state is understanding those auto assignments and where we can place members that have not been seen, to your point. So if they have no medical home, is there one in their general community? Or if they haven't seen their primary care provider in over a year, we're using that as an indicator as well to assign them to a new medical home. So one of the ways that I think we can work together from an industry standpoint is those auto assignments, and how do we create a synergy and a kind of a roster of individuals that are assigned to the FQHCs or the RRCs on a monthly basis, and work very diligently on how we engage the member population. Because typically the ones that are going to engage have had history with a primary care physician. Those that haven't are going to be the harder ones to reach. And so I do think we need to think creatively about how we do that work. And one other resource that I'll throw out, Maria alluded to it as well, was around care coordination. Every single managed care plan in the state, all 88 counties, has a requirement to have both a high-risk care coordination model, meaning that there are nurses and social workers on the ground in the field dealing with our highest or most intensive risk consumers. And secondly, we're required to do service coordination. And so there's always a resource to help you at the FQHC level as another extender to help reach people. And so we need to think, how do we leverage those resources, not needing to hire new people, to Maria's point about efficiency, but leveraging the assets each of us has to bring to the table.
Great, thanks for weighing in on that, Randy and Tracy, and I encourage all the panelists to just chip in as you want to add or probe or challenge. That'll just add to the value of this conversation. And in that spirit, I'm wondering, Jamie and Maria, do you have any reactions to the reactions?
No, I think we're hearing population management and chronic care management as the key terms these days. So when you talk about things that we can start doing today, I think that's where we start. It's a great organizational tool. It's not only, I think, a good medical treatment approach, but it also really helps you to prioritize your work and organize which patients you're going to prioritize first to reach out to. And when you have limited resources, the patients that would benefit best from those limited resources, to try and address them first. I think taking the approach of patient-centered helps us to encourage the patient to be invited to join our practice, as opposed to feeling like they're being mandated by someone they don't know to just show up in a particular place that they may not have any experience with. So I think all of these elements, although they seem kind of daunting when you think of them as multiple projects that you have to work on, they're actually all related. And I think if you create a process or a package, you can accomplish many of them with the same set of resources and just with a small change in the approach to things.
Okay, great, thank you. Well, sticking with this same question for just another minute or two, we haven't heard from you yet, James, so I want to see what you can add to the discussion. But before I hand it to you, I've got a couple questions that came in related, building on the points that have been made here, which I think you might be able to speak to. One question was around the comments you made, Jamie and Maria, about patients going to other practices and specialties and things happening out there that you don't have some control of. and wondering how to manage that. And then there's another question around here about attribution and, sort of keeping track of and uniquely identifying and then keeping track of patients as they move through the system. So I don't know if you want to hit those directly, James, or just wade in more generally on this particular subject about what people can do today, but I'll open it to you.
Yeah, I think I'll start with just more of a general overview, and then I think if Tracy or Randy or Maria or Jamie want to talk about the attribution more, since they're more relevant for that. But, I think that when you look at the question about value-based care and what should FQHCs focus today, in many cases, value-based care is such, again, a big term, right? And it's a change. And there's a lot of buzzwords that even we're talking about now, the population management and chronic care management and patient-centered medical home and episode of care. And a lot of times when we're talking with FQHCs, it's just overwhelming, right? It's almost like drinking out of a fire hydrant. So where do they start? Well, fundamentally, value-based care is truly a process and business reengineering of the facility. So looking at what the opportunities are, looking at inside at your own FQHC, and then identifying, doing an assessment, identifying where are the nearest, closest term opportunities. Because I think as part of this, one of the things we hear a lot is, well, we hear there's incentives out there, we hear there's programs, but we also know it's going to take time, it's going to take resources, it's going to take effort, and that's exactly what we don't have right now. So there's a lot of incentives and opportunities out there that several FQHCs just aren't pursuing because, again, the time, effort, and the cost. And one of the things we try to urge organizations to do is look internally and look at opportunities that can drive near-term immediate value back to the facility. Okay, and it's a baby step, and that can be everything and anything. And that can be things like, well, we know we want to move to value-based care, and today we've got issues with reporting, or today we've got issues with high no-show rates, or today we have challenges with referrals and getting referrals in and referral management, and really looking at what can we do internally to drive that might be easier to get some change that will afford you to drive operational efficiency, improve the bottom line, maybe grow some top line opportunities, and then better have resources to pursue some of the bigger picture type items. So that's the only comment, again, is many cases the value-based care as a term, and there's so many terms out there, it's just overwhelming for FQHCs. And if they take this opportunity to look within their organization and say, what can I do easy? Okay, and then how does that build on? And then the next step is, once they do their internal assessment, is start having conversations, right? I mean, have conversations with OACHC and with the payers and with the health transformation. Tracy pointed out some great resources that's available on the health transformation website. There's incentive payments that's available, chronic care management, PCMH. There's a lot of grants that are available. It does take a little bit of homework up front to identify, what are you best suited for, but there's also a lot of resources available.
Okay, great, thanks. And, building on that, in all of these discussions we've had, a lot of the questions come back to resources, and, it's been touched on a couple of times here, so maybe we could just dive into that just a little bit deeper. The question being, because resources are constrained and because all of this takes time and money, are there recommendations that you folks can make with regard to cost reduction or workload or workflow changes to free up resources for many of these new opportunities that we're talking about here? And since, Maria, you talked about how you're leveraging your resources, I'm going to go ahead and kick this one to you to start.
Okay, this is one of my favorite topics to talk about, so thank you for providing the opportunity. This is one of the most creative environments I've ever worked in, and I've been in large and small organizations prior to this. We have relationships we're fortunately located in Cincinnati, and so there are many, many, many university and educational facilities in our immediate geographic area, and this organization has found a way to tap into many of those universities and have developed a volunteer intern program. In some cases, the students are subsidized by grants or by external facilities, and the students just want to have an inner-city opportunity, work opportunity to get to know our particular patient population and come to understand their needs. In other situations, it's purely a learning opportunity. But we've learned to turn all of those various resources into additional resources for us. And so they're able to do the things that we never have time to do. And they love it. And they oftentimes bring a very fresh perspective. They're usually really quick whizzes at the computer. And so they pick up the medical records system very quickly. They pick up the data mining concepts really, really quickly. And are just really innovative and creative and a great source of energy to have in our environment. And it allows us to accomplish things that many of our, the larger facilities in our immediate area are not able to do. The other thing that they bring to us is many of them are in programs as community health workers or social workers, and so they do some outreach for us. They'll make those preliminary calls to the patients that are assigned to us and get them signed up for their first appointment. They'll call patients that have abnormal results and not speak to them about their clinical outcomes, but will help them with resource, making contacts with resources, figuring out transportation, giving them access to the food bank, to a variety of external resources that they wouldn't necessarily be able to accomplish on their own. They even go to the point of printing directions, finding out bus routes, doing just a variety of things that enable the patient to make the appointments. A nice outcome to having our VIPs do this is that if they weren't setting up the appointments for the external resources, we wouldn't necessarily know whether it happened or not, and if it did, where did it happen, and when did it happen, so that we can call and get follow-up reports from those resources. Because they make those arrangements, we have all of that information, and therefore, if the patient doesn't bring the information back with them, we're able to contact the external resources and get the information ourselves. So it's really closed a lot of the gaps that we've talked about so far on this call.
That's great. Thank you. Thank you for that. Randy, obviously you talk to and see a lot of health centers. Any thoughts on some really good, very specific things you've seen people do to reduce costs and free up workload or free up for resources to do kind of some of the things we're talking about here?
Yeah, let me turn this around just a slight little bit. And then first I want to just mention that Ohio's health centers are one of the lowest cost in the country. We spend somewhere between $500 and $600 a patient, more on the low end of the $500. I think the average nationally is $800 a patient, and one of the key northeastern states, I won't mention their name, that spends about $1,200 a patient. So just to kind of, if you take your, I think you have about 10,000 patients in the Crossroads, and you give them an extra $500, you can see what other people are doing in other states and the resources they have, and quite frankly, we compare very favorably to other health centers across the country in terms of quality outcomes. So just a quick nod out that we're already doing more with less. So as opposed to cost reductions, I want to turn the page to where are there nickels left on the ground? Okay, so first of all, is everyone using presumptive eligibility to make sure they're presuming folks eligible for Medicaid, to basically make sure that they're reducing their number of uninsured? And secondly, are you using your analytic tools appropriately to make sure that you're bringing in patients who need to be coming in, and you're not really penalizing the patient, but you know that you have certain protocols that diabetics say be seen at least once every 3 months. And I know, as well as everybody else in the health center world, is that patients are crafty about not coming in when they really should, because it's just it's kind of across town, and they don't want to. So they figured out mechanisms to keep you writing the prescription for a number of months when you really should be bringing them in for an assessment, the hemoglobin A1C. So are you coming through your appointment list and through your disease registries, and hopefully you have them, to make sure that people are being seen appropriately and to pick, like I say, I call them picking up nickels off the ground in terms of this is lost opportunity for revenue. So using the tools you have to enhance revenue. So presumptive eligibility, disease registry, appointment reminders, things of that nature.
Yeah, that's great, and thanks for redirecting that a little bit, that it's not, making resources available isn't just about cost reduction in centers that are already running it, pretty lean, but also, and perhaps way more importantly, additional revenue generation that serves both the patient and obviously the health center serving them. Did I hear somebody else wanting to chime in?
Yeah, Michael, it's Tracy. I wanted to add on to some of the concepts that Maria was mentioning when she was leveraging the VIPs or the student assets. Again, many of the managed care plans have almost concierge type of roles and services that are available for our consumers. Again, I'll reference ours. We utilize the term Members Matters, and they are highly trained individuals, either or on the phones. Basically, for our Medicaid population, they're on the phones. For the MMP population, they're on the ground. But they really are the glue, and they are the individuals that do a lot of the work that Maria was mentioning that the health centers also do, who have large populations of Medicaid consumers. We're looking for resources, helping connect them to their physician's offices, scheduling, transportation, and appointments, trying to really look at those social determinants and figuring out things like housing, food, safety, and really connecting the dots for the consumers that we can connect with, which takes us back to the member engagement side. The more that we can align with community resources and community assets like our RRCs and our FQHCs, the better off we all are, because we actually can find consumers, we develop a sense of trust, and we can actually do the work that we're all setting out to do. And oh yeah, by the way, if we do it really well, there's financial incentive in there too. So I really think that kind of understanding and asking additional questions of the managed care plans that you're contracted with to start the dialogue around what other assets or resources can be garnered to support the work efforts around the FQHC is an important conversation to have.
Yeah, that's great. Thank you. And, James, you hit on that too, the importance of just talking, right? Engaging in discussion. Obviously forums like this are maybe part of the answer, but it tends to be a more passive one. Much more important are those one-on-one connections with people who are on the ground implementing these best practices, organizations that have programs in place like Tracy has spoken about, et cetera. So in addition to encouraging everybody on the call just to start actively talking to the people that they're engaging to learn more about what's available, what else have you seen, James? You mentioned baby steps people could be taken. Any specifics you could share around that from this resource perspective?
Well, again, there's some great resources that's available. There's a lot of forums that's available, whether it's like the Greater Collaborative of Columbus, whether it's OACHC. There's, again, the purpose of actually sponsoring this webinar series was, again, to create a platform for discussion. So these are all very, very key topics, but that really can be anywhere. I mean, I think that OACHC is a great resource again, they're out there on the forefront, looking at opportunities that can drive awareness and drive opportunities to prompt discussions, and I think it just means getting started. A lot of individuals are kind of sitting back, thinking, I can't spend time right now. And again, what I'm saying, what I keep urging individuals is that it really doesn't take a lot of time, and you don't have to start with, again, eating the elephant in one bite. It's taking one step at a time, one baby step at a time.
Yeah, absolutely. And in the work that we're doing, since we're in the same place, can you speak to some of the specific little baby steps that organizations have taken to reduce costs or increase revenue?
Yeah, sure. I mean, I think that, and this kind of goes into one of the topics of discussion as well, is that looking at where the overall cost is, and when my discussion about interoperability, a lot of it is how do we look at what information do we need to gather to help us understand how to better serve the patients, and part of that is sharing information with other clinicians and other providers, but a lot of that as well is dealing with the non-clinical information. We talked, I think, at the last webinar about the social determinants of health and how, if we're working with, an example, Columbus Public Health with improving infant mortality, and a big objective for them is once we do the proper needs assessment and we understand the patient a little bit better, how can we better refer or recommend that patient to other services in need, whether that's moms-to-be or food bank services or whatever it might be. So I think, that the social determinants of health and being able to identify, what partners can we collaborate that may not be part of the clinical setting, but part of, the environmental setting or the psychosocial setting or the social services setting, that we can collaborate, work together, and best meet mutual objectives.
Okay, thank you. So before I move on to the next question, just in the spirit of encouraging dialogue, if you haven't sent me a question already, please send me your questions via the chat box in the lower right-hand side of the screen. I'm Michael Schuchter, and it'll say presenter in parentheses. So if you're listening and you have questions, please get them over to me, and we'll get them asked. But while we're waiting for those to come in, more of those to come in, I'd like to build on, both Tracy, you and James both touched on social determinants of health. And, research indicates that maybe 80–90% of health issues are based on non-clinical factors. And I know, Maria, you talked about being at the front lines with regard to making community and social services connections for your patients. And I'm just curious of, and I'll kick this to several members of our panel ultimately, but we'll start with you, Marie, if that's okay, because I want to try to find out who's doing a really good job of that and what are some of the key determinants of success. And I guess the final sub-question is, what's getting paid for and by whom? So Maria, could you weigh in on this first?
Sure. One of the things we've been doing most recently is not just treating the asthma, but then looking at the social issues that are causing the asthma. So environmental, pets, allergies, smoking, all of those kinds of things, because we need to look outside of the clinical realm to look at the causative factors, and then our patients, thinking of us as a medical home, rely upon us to help them with those factors as well. So that interoperability that James spoke about is becoming more and more critical to us. We find ourselves interacting with other organizations that are as limited in resources as we are, and so it really cries out for better coordination between us so that we centralize those activities that we're all spending resources on and duplicating efforts and still falling short of our patient needs. So our focus lately has been in trying to collaborate more with those external resources, tie them back to the patient. We're finding our patients to be incredibly pleased with that approach and just really touched by that additional level of help. And those things drive incentives. So all of these things that seem discrete are all starting to connect. The puzzle pieces are starting to pull together and make some sense here. So I think we're definitely onto something. It is huge, but we're taking small bites with small populations, sometimes just one patient at a time, and putting together the resources and learning each step of the way about what we can then apply to a larger patient population.
Okay, great, thanks. And Tracy, I know you've touched on this too and have already shared some thoughts. Any other or any specifics you could share with regard to this particular issue?
Yeah, actually, I think I can just lend a little additional foundation. The managed care plans each have an agreement that we have to sign with the Ohio Department of Medicaid, and you'll hear us refer to it as the provider agreement. In the context of that agreement, we actually are required to have a community resource guide of some sort, whether it's electronic or phone bookish or however it works. each of us is required to keep up with the community resources that are available in any local community that we serve. The reason I bring that up is it's another asset. It's another opportunity for us to work collaboratively. A lot of those garage neighborhood types of resources come in and out all the time. And so keeping those tools refreshed and current and meaningful are important. But we are also required to do it. And so how do we, I haven't solved the puzzle today, but I do open the door for the conversation. How do we use those local assets that are already in the communities on the ground, utilizing these resources that work and that we have success with? How do we share that information collectively across the managed care plans as well as our FQHC partners? And so that's an industry opportunity, I think, for us to think differently. But just for folks to realize, we do have a requirement to do such. Again, my United example is a little different than some of the other plans. We go beyond just the phone book strategy or the online tool, which is very successful. We have that as well. But those Member Matters team members that I was talking about, they have access to an accelerated service that is a social service connector. And for individuals, we actually make referrals, but not only do we make the referral, there is a social service coordinator that walks them through the application, that tracks completion of the application process, that makes sure that the bed that we ordered or the food service that we coordinated or the diaper service that we found actually occurs, not that we just recommended it, but that actually comes to fruition. And I think that there's an opportunity, again, for us to collaborate and figure out how we use those resources in the most wise fashion.
That's great. Thank you. Anybody else want to weigh in on this particular question around social determinants of health and making these necessary connections and managing that?
This is Randy. I'd like to just add another word here. 3 of our community health centers are also community action agencies, including the ones I used to work at. And so they provide their own transportation. They operate Head Start programs. They have the WIC program. They run the senior citizens programs. In many cases, they're doing the workforce programs for the counties and endless numbers of things. And basically, do you think that they're happy? No. Okay, they're still, as Maria also mentioned, that this is just a never-ending sort of thing. And so you can get into a situation at a health center and think, if I just had one more program, I've got this licked. Well, you never have it licked. But if you can't run the program yourself, you need to reach out and make that network. And so whether and probably as formally as you can make it happen, instead of just as Tracy mentioned, not just a phone list, but an actual relationship. So strike out and make a relationship with the director of health if they run the WIC program to make sure their next office, their next WIC office is in your clinic, and you can provide space for them. Make sure that you've reached out to all the other groups in your community that you have an active collaboration with. So it's never going to, it'll never end, as Maria said, but you can make a dent in it.
That's great. And, one of the things we're trying to do on this call today is, hear about things that people can do today. And one of the things that's coming through loud and clear to me is, at a minimum, you can pick up the phone and call someone today. There's somebody out there who could help serve your population that you can deepen a relationship with. And so often, well, almost always, these things just happen by picking up the phone and starting that dialogue. So great. We talked about all the things that the FQHC can do, what the payers can do to help, what all these organizations in the community can do. But, the one common denominator in all of this is the patient. And I'd like to see if we could spend a little bit of time talking about some best practices either you've observed or implemented with regard to engaging patients in the management of their health. And if you have examples of health centers that are really moving the needle on that, and any insight on how they're measuring their impact, that would be really helpful. And I'm going to start with those of you who are in the patient engagement business every day, and will be again as soon as you hang up the phone on this call. Jamie and Maria, can you kick us off with some thoughts?
Well, The first thought is the very basic one of getting in touch with the patient, reminding them of their appointment. We're in an area in Cincinnati over the Rhine, which is a poorer area and on the west side of town. And there's a lot of patients that we have that only have a cell phone and they only have limited minutes, so they don't really want to take our calls. They don't want to waste their minutes on a call from the health center. So what we've done is we've worked with Insight actually on being able to text our patients. Texting is free. They have unlimited text. They've been open to receiving the text. And it has been, it's only been a short time, but we've already seen a decrease of 3 to 4% on our no-show rate. So, you know, the more patients we're able to get in, the better our productivity, the more resources we have. So that's one of the very basic things that we have done to try to engage the patients, is to text them instead of using the telephone.
And if I might add, this has really shown us how effective this means of communication is, and our patients have been so receptive and positive about it. Our plan is to try to expand that to more population management so that we can use the same methodology for reaching out to our diabetics and reminding them about their 3-month appointments, about picking up their insulin, about just a variety of little snippets that can come across as a text as a quick reminder to the patient to try to keep them on path and engage them more deeply in their own care.
Hey guys, it's Tracy, and I wanted to just jump in here because we have some built-in barriers to texting our patients with some state limitations on communications and what's allowed to be sent and things like that. So a quick hit opportunity, I think, is for those who've cracked the nut on this particular opportunity to text your patients, there might be a great segue to working with your managed care plans on creating kind of that gap in care reminders and outreach lists and bringing people in for their appointments and things, because like I mentioned, we have some limitations, especially with the files that we receive, but if you have more active phone numbers and the ability to do text, it might be a great partnership that we can do fairly quickly.
Yeah, 100% of our patients don't have these cell phones, but we certainly are reaching more people this way than we were by trying to make phone calls. And to Jamie's point, we've actually seen a 50% reduction in our no-show rate. Our cancellation rate has also gone up a little bit because they're offered the opportunity to cancel rather than just not show up.
Yeah.
But that allows us to reschedule those appointments and use that time slot more effectively. So all in all, it's been a win for both the patients and for the Crossroad and for other patients who are waiting for appointments.
Yeah, and to follow up to that, if I think about the resources or the assets that most of the care plans, managed care plans have available to do, finding phones and paying for minutes, or actually buying the pre-purchased phones that we could maybe supply through the FQHCs where we have large panels of consumers, that for those who don't have them, getting them one. So again, I think there's some creativity that we can think about differently after today's conversation.
Absolutely. That's what I was alluding to at the beginning of our call about working smarter, not harder. I think using the things that are presently available to us and really going back to the basics and listening to the patients. They were telling us either directly or indirectly that the phone calls weren't working, and we kept trying anyway. When we finally took a step back and said, okay, well, if you're not going to answer our call, will you answer our text? And they said yes. And so here we are down this new path, and in about 5 weeks, we truly have reduced our no-show rate by 50%.
Wow, so one of those baby steps that you know, James alluded to, right? Something so simple that if you have the tool to execute on it, can actually have a big impact. So that's great.
And then talking about the use of resources is the other thing. It used to take a medical assistant 2.5 hours to make the phone calls. It takes none of that time to send a mass text out to our patients with reminding them of their date and time of their appointment. The other thing is our patients like it because they can refer back to the text if they forget the date and time, where they didn't have that with a phone call. So just little tidbits that we're learning as we go that are helping us to build bigger and better projects further down the road using the same technology.
Absolutely.
Great. Did I hear you trying to weigh in, James?
Yeah, I think, Tracy, what you just kind of brought up as far as how you can start working with the FQHCs on the phones and the minutes, I think it's such a creative opportunity. You know, when we start talking with the FQHCs, in many cases, they feel like, well, our patients just can't. You know, they don't have the phone or whatever it might be, and you know, there's studies after studies are showing now that you know, even the patients at the FQHCs they have phones and they use it predominantly. Those that again on the minute side, that's always been a challenge. But when you talk about patient engagement, being able to leverage the phone is absolutely part of the mainstream right now. And if we can help look at ways to basically fill the gap, as you know, for those that have challenges because of minutes or those that may not have phones, it's such an excellent medium. Whether it's just again the appointment reminders, whether it's being able to push out you know, care plan reminders to the patient and getting responses back from the patient. That's the other thing, is that, you know, with patient engagement applications now, especially the ones that we've been working on, it isn't so much one-way communications text out. It's actually interactions. It's communications back. If the patient isn't able to make their appointment, well, what is the reason? If the reason is I have no transportation, well, that's an opportunity to basically fill that gap and get transportation available. If the patient isn't taking their prescribed medication, providing the medium for the patient to say, I'm not taking my medication because I can't afford my medication, or because it makes me feel ill, or whatever it might be. That's all part of this care coordination process. And I think that the phone and patient engagement absolutely is the key to you know, and everyone wins as part of that. You know, once the patient's engaged, the interactions are there, the quality metrics are higher, and everyone benefits.
Great. Well, thank you. Thanks everybody for weighing in on that. We're nearing the end of our time here, so I want to end everybody on time. I want to thank everybody involved in this program. Our sponsors, OECHC, Cardinal Health, United Healthcare, and us, of course, at Insight Health Systems. But what I really would like to do is encourage everybody on the call to continue the dialogue. Every single thing that's been talked about today has started with a conversation. It's started with the identification of a need and then a conversation to find a way to fulfill that need. And although this is such a complex topic and there are so many things that can and should be done, the other thing that we've heard here today is baby steps is the way to, you know, get that elephant eaten. And sometimes these very simple ideas can really move the needle. So on your screen, you see the email addresses of everybody involved in the call today. These are all very generous, helpful people who I'm sure would very much welcome a connection with you and an ongoing dialogue about how we can all work together to better serve patients and benefit the FQHCs in Ohio. So thanks to all of the panelists. I really appreciate you taking the time. Thanks to everybody who joined us today. It is our intent to continue to work with our sponsors and new sponsors as well to identify needs for education and dialogue and interaction, and find ways to continue to roll out forums like this to serve the community. So thank you very much. Look forward to connecting with you in a variety of ways moving forward.